Welcome back to the Ninja Nerd Podcast. Today we've got a great one on myeloproliferative neoplasia. What diseases make up that, Zach?
Ooh, it's a lot of stuff.
Okay.
A lot of stuff. You got polycythemia vera, right? You got some jacked up red blood cells, too many of them. You got essential thrombocythemia, too many platelets. You got, there's another one, we'll talk a little bit about it, but we're going to talk about more in chronic leukemias, but it's chronic myeloid leukemia. You get too many granulocytic white blood cells. And then there's like this little weird one. It doesn't really fit into like the pathophysiology, so we just say it's primary myelofibrosis. It's a lot of bone marrow fibrosis. But we'll talk about how that all comes into play. But those are the primary ones that we'll discuss. These are rare, and so when we talk about these, you're really thinking about this in a true clinical scenario for an exam. You're not going to see these a lot in clinical practice, but if you see one that's the most common, I'd say it's the polycythemia vera type.
All right. Well, before we get started, please, as always, guys, make sure to like, comment, subscribe to our channel. Most importantly, check out our website. We've got a lot to offer there. Please subscribe. It really helps us, and then we can continue to make more free content.
Yes, right. Yes, sir.
All right. Let's get right into it here. We have 3 cases in total. I'm going to start it off with case 1. We have a 65-year-old male presenting with recurrent abdominal pain and redness in his extremities. The patient describes multiple episodes of abdominal pain over the past year, which resolved spontaneously. He also reports burning pain and redness in his hands and feet, exacerbated by warmth. He denies recent infections, trauma, or changes in medications. He has a history of gout and was treated for a DVT 2 years ago. He also states that he has noticed that every time he takes a warm shower, he gets extremely itchy afterwards.
I probably got this disease too. This happened to me.
Yeah? Will you get itchy like that?
Yeah, I've had that a couple times, but yeah, it's always like a classic one. We'll talk about a little bit what that means, but that's a classic finding of aquagenic pruritus.
Aquagenic pruritus.
Yeah, it's a pathognomonic. We'll talk about what that means later, though.
Well, let's get into his past medical history and some medications. We have gout. DVT, as we said, was 2 years ago. He's on allopurinol, and he's on a low dose of aspirin. For his exam, we have vitals, BP 135 over 85, heart rate is 80, temp is 37 degrees Celsius, and his O2 sat is 98% on room air. His skin is noted for erythromelalgia of his hands and feet, abdomen, mild tenderness in the right upper quadrant, no organomegaly, and there is no lymphadenopathy or petechiae present. For his labs, we get the following back: hemoglobin of 18.5, hematocrit of 57%. We do a peripheral blood smear, and we note hypercellularity with normal red blood cell morphology. That's it. That's all the labs we got.
I know, that's not too bad.
That's not too many.
Yeah, I like that.
That's nice.
Makes you, if you got that much Zen-tensivist type of like ability to take a history and physical exam and pretty much come up with at least a suspicion of what you think it is, you only need a few labs to really come to your diagnosis. So that's always good. That's one of the things that makes these kind of tough, is that they're really, you have to have a high degree of suspicion for these to even test for them, you know what I mean? And so sometimes they'll only be incidental findings because they cause abnormalities in your CBCs. So really, you either look for the findings that make you want to test for it and then get that CBC, or you just like, hey, the patient's coming in, they're getting blood work for their annual physical, and then you get a CBC and you're like, oh, this is weird. Hey, do you have any of these like abnormal findings? Because then you start thinking about it. So with this one, we got kind of a nice intro that they have symptoms, and then now we get the CBC and it kind of starts to confirm some things.
I would cost my institution thousands. I would order every test imaginable.
Yeah, everybody gets a pan CT scan.
Everything.
Every lab possible.
They would get the most thorough workup, though.
Yeah, they would.
But yeah, it'd be a needless spending.
Yeah.
All right, so let's get right into it here. What I'm noting here first, Zach, is the hemoglobin is through the roof. Hematocrit, not too good.
No, they're both pretty high. So there's a couple different findings here that are concerning. So if we look through the history and the physical, and we're talking about MPNs, right? So there's polycythemia vera, essential thrombocythemia, chronic myeloid leukemia, and then primary myelofibrosis. So when I see here that they had a recent history of a TVT, all right, so there's a history of thrombosis. That's not uncommon in a patient who's 65 as long as they have particular risk factors, but that's one thing I'm noticing. The aquagenic pruritus is the other one that's super pathognomonic for polycythemia vera.
Okay.
All right, so that's one thing. The second one is the burning pain and swelling and redness in the hands and the feet, which are exacerbated by warmth.
Which is that's the erythromelalgia?
Exactly. So that's also common in essential thrombocythemia or polycythemia vera.
Okay.
And then when I look here, I also notice they complain of abdominal pain. And then on their abdomen, it's mildly tender in the right upper quadrant.
Yep.
That could be a potential sign. It's not guaranteed, but you just start thinking about it in polycythemia vera. If I have erythromelalgia, I have a history of recent thrombosis in the past, and then on top of that, their hemoglobin hematocrit shows that they have high red blood cells, or at least red blood cell mass, I'm concerned for Budd-Chiari syndrome, which is a clot in the hepatic vein, and that can cause the liver to get bigger, and sometimes it can even cause ascites too. So I would have ordered an LFTs to see if those were a little bit elevated, and I would assess for any types of ascites as well, which could be a complication of Budd-Chiari syndrome.
So if you had gotten LFTs, would they have been bumped?
They probably could be. I would say it depends upon the severity of the thrombosis of the hepatic veins and if it causes significant hepatomegaly. And this is mild tenderness in the right upper quadrant, but the liver isn't super hepatomegalic, or there really is no hepatomegaly. So it'd probably be, if anything, very, very mild. So it's probably not a severe hepatic vein thrombosis, but if you get good enough, it can cause complete congestion of the liver. That thing can blow up like a balloon, and that can start causing organomegaly where you could palpate it, feel it, and then you'll start seeing those LFTs rise. So that's what I would say.
You're definitely thinking, though, polycythemia vera.
Yeah, and so the question always comes down to, is it primary or secondary? But
what's the difference between those two?
So the difference really when it comes to that is knowing what's the trigger. So when you think about going back to physiology, you got the hematopoiesis. So you start off with a stem cell, becomes a myeloid stem cell. Myeloid stem cell can either become a red cell, a platelet, or a white blood cell. How the heck do they know which one to become? They need a signal, and EPO, or erythropoietin, is usually that signal. So EPO has to act on a receptor. So then you have to ask the question, is it a problem with EPO being too high that is driving that pathway, or is the receptor being stimulated from some other reason? So if it's polycythemia vera, and that's just a fancy way of saying primary polycythemia, it is usually due to autoactivation of the EPO receptor. So there's an enzyme inside of that receptor called the Janus kinase 2. That becomes mutated, and you don't need to have EPO hit the receptor. It just sends signals down. And so it's like if EPO was there just hitting that receptor nonstop. And so because of that, it sends signals down to tell that myeloid stem cell to turn into tons of red blood cells. So that's one of the biggest things. The second cause of polycythemia, which is not due to the receptor problem, is it's due to high EPO. And then the only reason you make high EPO is because you have hypoxia chronically. So COPD,
yep,
like chronic bronchitis, that's a big one. Obstructive sleep apnea, which I have. Unfortunately, I got the fat neck. But usually it's chronic sleep apnea where you're not using CPAP at night. Interstitial lung disease, and then the other one is high altitudes. So if you live in areas like Denver, they technically have higher levels of EPO than we do here. And you know how people they train? You ever hear that in the past? I'm going to go to Denver or the higher altitudes to train.
Right. Yeah.
It's because at those high altitudes, there's less availability of oxygen. So then they cause EPO levels to go up. They make more red blood cells, so they have more oxygen carrying capacity for these different types of endurance events. So
and the Denver Broncos still suck.
Yeah, I know.
It's not working for them.
No, it's not working for them. Hey, I mean the playoffs, Bo Nix, but still
they're getting there.
We'll see.
They're getting there. Yep.
But that's the big concept is a hypoxia driven. And so you'd have to get an ABG to really suss that out and look at their history. And then if your ABG is normal, you don't really have any chronic hypoxia or any kind of lung diseases, then you ask the question, is it a renal problem? Is there a tumor in the kidney that's pumping out erythropoietin? You'd have to have some risk factors there, though. Look for the patient to have hypertension. This patient does not. And then the other thing is look for flank pain or a mass, and then hematuria. Those are usually the signs that a patient could have a renal cell carcinoma, and you'd have to scan their belly to find that. So that's the ways that I would look at it. But I would definitely say get an EPO level.
Right.
That's going to tell you right away if it's primary or secondary. Look at their history, right, as well to really suss out what could be the cause if the EPO is high or low. And then I would also get an ABG. And then I would even, an ABG isn't necessary, history could be enough, but then I would also order a JAK2 mutational analysis. Because if the JAK2 comes back positive, it's primary.
Right.
So that's what I would do if I could order that.
All right, well, let's just go ahead and say we got those 2 tests. We got an EPO level and we have a JAK2 mutation test.
Okay.
So for our patient here, we have an EPO level coming back as low.
Okay.
And a JAK2 mutation as positive. So we're thinking then primary.
Yep, that's definitely primary polycythemia or polycythemia vera.
Now, does this rule always apply? So if EPO is high, JAK2 mutation is negative, it would be secondary.
Yeah, and then you just have to suss out which one is it. So
Right.
then that's where the ABG in the history could come into play, or the CT scan of the abdomen.
To find the underlying mechanism.
Exactly.
Okay.
But if it's low, that tells me, and if you look at the criteria, there is actually a criteria. You can find it up to date. And it shows there's like 3 major criteria for diagnosing polycythemia vera. And then one of them is having a JAK2 mutation. The second one is usually having some type of particularly evidence of like a bone marrow biopsy that shows this type of, we'll talk about it later, lots of red blood cells. And then another thing is having the elevated hemoglobin and hematocrit, so having that evidence.
Right.
But the big thing is, a minor criteria is the EPO levels. So you need to have low EPO levels. And so there's different ways that you can diagnose polycythemia vera, but the big thing is if you have elevated hemoglobin and hematocrit, you have potentially a bone marrow biopsy that shows trilinear hypercellularity, or you have a JAK2 mutation, you pretty much got polycythemia vera. So those are the 3 major. But if you have like 2 of those major and then a low EPO level, that's a minor criteria, that's enough to make that diagnosis as well. So
for our patient, let's just go ahead and say he does get that bone marrow biopsy.
Okay.
And now we are showing trilinear hyperplasia.
Yeah, so that's definitely...
You got a confirmation.
Yep. And so here's the thing. When people think about polycythemia vera, it's easy for us to teach it this way because it's not complicated. Because when you look at myeloproliferative neoplasia, it actually hits, for polycythemia vera, you can have increasing red cells, but in 50% of the cases, you can have increasing white cells and increasing platelets. So that's where that trilinear hyperplasia comes into play, because that myeloid stem cell can turn into lots of red blood cells, lots of platelets, and lots of white blood cells. So that's why we say that there's lots of trilinear hyperplasia. But in that polycythemia vera is probably going to be one of the biggest ones that can lead to almost all the cell lines being increased. It's just predominantly the red cell line.
Considering his age, his history, how would you go about treating this patient?
So the biggest thing is thrombosis is a huge complication for these patients. Look, he's already had a DVT. He probably has Budd-Chiari syndrome. So I'm likely going to have to consider anticoagulation to get him through this part. But then afterwards, preventing those thrombosis in the future is the key thing. And the key way to do that is their mechanism is hyperviscosity. So they have too much of these red cells. And so I'm going to have to bloodlet them, phlebotomize them. So I'm going to take some of their blood, probably like every week or every month. And my goal is to get the hematocrit to like less than 45%. So I'll do that until I get that goal. And that's going to help to reduce the viscosity, help to prevent thrombosis, and help to prevent hyperviscosity syndrome. The other thing is that these patients probably also have lots of platelets. So if polycythemia vera, it's trilinear proliferation. And so they could have lots of platelets. With lots of platelets comes lots of platelet plugs. What's the best drug or the most common drug that we utilize in medicine today to inhibit platelet aggregation?
Aspirin.
Yeah, exactly. So I'd probably put them on a low-dose aspirin, phlebotomize them if need be weekly or however frequently, just to get that hematocrit less than 45.
Which the patient was actually already taking,
Yeah,
a low-dose aspirin.
Exactly. So I would just add in the phlebotomy, get that hematocrit down, and I'm reducing the risk of thrombosis. If for some reason their platelet levels are really high, and here's what's weird. So we always attribute thrombosis due to platelets or red cells. You know what the highest predictor of thrombosis is in these patients? An elevated white cell count. Don't know why. We think it's due to like they may release these like little things called nets that cause this, but funny enough, the most likely predictor of thrombosis in any MPN is a high white cell count. So if a patient has lots of platelets, they have lots of white cells, and they have lots of red cells, super strong chance that they could develop thrombosis. We should knock those cell lines down. And so in that scenario, I would consider something like hydroxyurea. So hydroxyurea is a pretty good drug, and what it's going to do is it's going to basically prevent that stem cell from proliferating into myeloid stem cells and prevent it from proliferating into red cells and white cells and platelets. So it'll drop those cell lines. So you have less red cells, less viscosity, less platelets, less platelet plugs, less white cells, less risk of the nets and thrombosis. So that's the concept that we would do there. We usually do it in certain high-risk scenarios. One, The most high risk of thrombosis is if they have, again, those white cells that are high. What we like to say is the patient older, so greater than 60. The other one is, do they have a history of thrombosis? This patient did.
Yeah.
They had a history of a DVT, and they probably have Budd-Chiari syndrome as well.
And they're over 60.
Yeah, and so I would probably put this patient on hydroxyurea, knock those cell counts down, and try to get them to the point where there's less chance of them developing these thrombosis.
Cool.
Yeah, that would be the big things. The only other thing that you could consider after hydroxyurea is if they're not getting any better.
Yep.
You could give a drug to block the JAK1 and JAK2 enzyme, and it's called ruxolitinib. So that's the only one that I would do. So I would start off with keep their low dose aspirin, phlebotomize them, get that hematocrit down. I'd probably do some doses of hydroxyurea to knock those cell counts down, reduce the risk of thrombosis, and if that didn't work or they couldn't tolerate it, then I would consider ruxolitinib.
Okay. Case 2.
All right.
We have a 55-year-old female presents with recurrent transient ischemic attacks and gum bleeding. The patient reports intermittent speech, slurring, and dizziness over the last 3 months, lasting 10 to 15 minutes per episode. She also notes spontaneous gum bleeding over the past week. There is no history of trauma, medications, or recent infections. She denies smoking or alcohol use. For her past medical history, she has a history of gout, and she had 2 miscarriages in her 30s. She is currently taking allopurinol. For her exam, we have vitals, BP 125/78, heart rate is 82, temp 36.8 Celsius, and O2 sat is 99% on room air. For her head, eyes, ears, nose, throat, bleeding from the gums we have. Neurologic, she is alert, no focal deficits, and her skin, we note petechiae on her forearms. We have labs, we get the following back. A platelet count of 1.2 million.
That's terrifying.
That's really scary.
Yeah,
if I saw that, I would shat myself.
I love it.
Peripheral blood smear we also get, and we see large hypogranular platelets.
Yeah.
So we have a platelet problem here.
We got a big platelet problem here.
My first question for you, Zach, is what do the symptoms in labs suggest?
So with this one, like when you first hear like 2 miscarriages in their 30s, the first thing that comes to my mind is like, oh, could this be an antiphospholipid syndrome, especially if they're having thrombosis? But then they have bleeding and they have a platelet count that's 1.2 million.
Yeah.
Antiphospholipid syndrome doesn't cause platelets to be 1.2 million. If anything, they cause them to be low. And they don't often cause bleeding either. And so that right there was like, all right, that's unlikely. And also, guess what we're talking about? MPNs. But it's just something that's funny because usually on your exams, you see, multiple miscarriages and all these other things. You think about that. But in this case, it's one of those MPNs, and I see the platelets are skyrocketing high. That makes me think of central thrombocythemia. So when I got a platelet count that's like super high, and so less than 150 is thrombocytopenia, greater than 450,000 is going to be thrombocytosis. So that's one thing. But here's the thing. The chances of a patient's thrombocytosis being due to essential thrombocythemia is like 1 to 2%.
Oh, wow.
So it's like really low. So the chances of it is pretty low. So you always have to rule out secondary causes. The other thing is that this patient has TIAs probably from the multiple miscarriages. Probably got like microthrombi in the placental vessels that cause these like placental ischemia, and that's why they ended up getting the miscarriages. And then they have bleeding. So there's thrombosis, bleeding. So when I think about that, here's what's weird. High amounts of platelets do induce this risk of microvascular thrombi so that she can get TIAs. And that's probably what caused these events that she had where the intermittent speech slurring and dizziness.
Right.
But probably no underlying neurological deficits that's permanent because she had no infarction. And then gum bleeding. This was weird. When platelets get greater than 1 million, some textbooks say 1.5 million, it binds to like free von Willebrand factor and sequesters it. And so if you have all these platelets that are sequestering von Willebrand factor, if you break a hole in a blood vessel, small little hole, platelets are supposed to go and bind to von Willebrand factor in that hole and help to plug it. But if you sequester all the von Willebrand factor with a bunch of platelets, guess what? You have less of that free circulating around. So when other platelets are coming by, it has nothing to stick to be able to induce a thrombus or to actually help to block off that hole.
Yeah.
So because of that, they start bleeding. So platelet levels are greater than 1 million, you do run that risk of bleeding. So that's the big thing for me is seeing the evidence of having thrombosis, having bleeding, and having a super high platelet count. The other thing is the peripheral smear. Large hypogranular platelets is almost always suggestive of a primary or essential thrombocythemia as compared to a secondary thrombocytosis. Secondary thrombocytosis, usually the platelets are normal appearing. So if the platelets are very big, that means that there was a problem with the actual differentiation process. So right now, I'm definitely thinking essential thrombocythemia based upon the evidence of thrombosis with the TIAs, with the placental ischemia causing the recurrent abortions, and then the bleeding, the gingival bleeding, the elevated platelet count, and then the large hypogranular platelets. That kind of tells me it's likely essential thrombocythemia.
Man, this patient could get like poked and she'll start bruising.
It's definitely possible. Yeah. And that's why like we actually like, so here's the thing you run into with these patients. They're high risk of thrombosis and they're high risk of bleeding.
Right.
Do you give them aspirin? It's tough, right? So that's why it's always a caution. It's a risk versus benefit thing for these patients. If they're bleeding, probably should hold the aspirin. But if they're having thrombosis, then you should probably give them aspirin. And so it's kind of like a tough battle where you got to just be very careful and kind of weigh the risk versus benefit because you want to prevent thrombosis, but you also don't want them to have any further bleeding.
Flip a coin.
Yeah, it's a tough one. Yeah.
Next question, how do you differentiate ET from reactive thrombocytosis?
So essential thrombocythemia is usually there is no problem where TPO, so what's happening in this one is just like EPO receptor, except in this case it's a TPO receptor that helps to turn the myeloid stem cell into megakaryocytes and then the platelets. So if TPO is causing, if it's high, it'll drive this pathway. But if you cause autoactivation of the TPO receptor, guess what's another, and that same enzyme that's in the EPO, it's also in the TPO, the JAK2. So if you have a mutation in the JAK2, it'll increase the pathway of the TPO receptor. And then on the outside, so that's on the inside, the JAK2. On the outside, there's like this like little like Y structure. And there's one part of it that's called the MPL protein. And then there's another like chaperone protein on that as well called the CALR. If you have a mutation in the CALR, the MPL, it causes the auto activation and keeps stimulating the inwards pathway. So if you have a CALR mutation, MPL mutation, or a JAK2 mutation, doesn't matter if TPO levels are high, you're just going to drive that pathway, and that's going to lead to high platelet levels. So that's one thing. The second thing is that you have to rule out other causes of thrombocytosis. Remember, I told you, it's very unlikely that it's essential thrombocythemia. The most common causes of you developing a reactive thrombocytosis, that your bone marrow is pumping it out, is your liver's producing TPO and the liver's being stimulated by some reason. Infection and inflammation is the most often cause or common cause. So if a patient has an infection going on, they're releasing cytokines that's going to cause the liver to make TPO. If the patient has some type of inflammatory disease like SLE, RA, or even malignancies, that can also cause it to produce these production of TPO. So that's the two big ones. And so usually in inflammation or infections, there's acute phase reactant proteins that the liver makes, and you could test for those. It's CRP and ESR. They're generic. And a patient who has essential thrombocythemia, they shouldn't have a super elevated ESR and CRP. It should be relatively normal. So if I check an ESR and CRP and it's elevated, it's unlikely to the degree that it's the essential thrombocythemia, but it's not guaranteed. The other thing is iron deficiency anemia is a really, really common cause. I see it all the time in the hospital. When a patient's iron deficient, it does trigger the liver to start producing TPO, and it also causes an increased production of EPO. So your bone marrow is trying to compensate and make more red blood cells, but it also makes more platelets. So whenever I see a patient who has anemia, I check for iron deficiency. So I check an iron panel. If the iron panel came back normal, it's unlikely iron deficiency, and it could be essential thrombocythemia. So that's what I get an iron panel, CRP, ESR, do a good history, and I would order the JAK2 mutation analysis.
Yep.
And then in certain scenarios, based on if it's positive or negative, I would order the MPL and the CALR as well.
Okay. Well, we get some of those tests back. We do the CRP and ESR. That comes back normal.
Okay.
Iron panel is normal. And our JAK2 mutation is positive.
Cool. Yeah, and so that's definitely likely essential thrombocythemia. I would say if the JAK2 came back negative, it doesn't mean that it's not possibly still essential thrombocythemia. If that came back negative, then I would order the CALR and the MPL mutational analysis. And if that came back positive, it still can be essential thrombocythemia.
Gotcha.
The reason why I say that is in polycythemia vera, 98% of the causes of polycythemia vera is a JAK2 mutation.
Wow.
In essential thrombocythemia, the JAK2 mutation only accounts for 50% of the causes.
So those other ones could be accounting for the other half.
Yep.
Got it.
Exactly, yeah.
Would you also do a bone marrow biopsy like we did before?
Yeah, so you got to confirm it. So you do that. You definitely want to confirm. So I would do that and look to see if I find like lots of megakaryocytes. And that's basically a precursor to platelets. So if you have tons and tons and tons of these like megakaryocytes, that's usually going to tell me that I have essential thrombocythemia.
So for our patient, we do get a bone marrow biopsy, and it's showing megakaryocyte hyperplasia, confirming the ET.
Yep, perfect.
We got it.
All right.
All right, now that we have this diagnosed, we've got everything we need, what do you do to treat it?
It kind of goes back to our problem, like do I do aspirin or not, right?
Right. What do you do?
I'd say in this patient, I would be cautious, but I want to reduce the risk of thrombosis. I don't want him to get a stroke. Gum bleeding, I'll probably tolerate that, to be honest with you. So, but it's kind of the same thing if they're greater than 60 or they have thrombosis or their platelets are kind of greater than 1 million and they're not really bleeding, I would do low-dose aspirin. So their platelets
she's less than 60, so we're a little okay with that.
So she has the history of the TIA, and then she's had the recurrent abortions. I would be careful. I probably would just say maybe let's give it a little bit of time, see if the gum bleeding resolves, but I probably may consider the low-dose aspirin. What I'm going to definitely want to do for this patient for sure is I'm probably going to want to do hydroxyurea. That's probably what I would do. This is not, patient's not pregnant, right? No. So female. Okay. 55-year-old female.
She's 55.
Yeah. So
if she's pregnant, that's a problem too.
Yeah, exactly. So the reason why I ask that is if they're young and they're pregnant, we want to stay away from hydroxyurea because it can be teratogenic. So I would probably do interferon alpha, but this is not that case. So for this patient, they have thrombosis. They're not greater than 60, but they have platelets that are greater than 1 million. I want to knock the platelet count down. I want to really help to reduce the risk of further thrombosis. So I'd probably do hydroxyurea and then maybe hold the aspirin for a little bit, get the platelet count down, and then after that, I would consider restarting the aspirin to prevent the events.
Okay. All right, well, that wraps up case 2. Let's finish it up with case 3 now.
Okay.
We have a 60-year-old male presenting with fatigue, abdominal discomfort, and weight loss. The patient reports progressive fatigue over the past 6 months. He has also experienced early satiety, significant weight loss, and vague abdominal discomfort. He denies fever, night sweats, or recent infections. His past medical history is pertinent for hypertension. He's on lisinopril. And for his exam, we have vitals, BP 130/85. Heart rate is 84. Temp is 36.7 Celsius. And his O2 sat is 97% on room air. Abdomen, we have massive splenomegaly extending to the pelvis.
Oh my gosh.
You're telling me that spleen's going toward his pelvis?
That's huge. That's insane.
It's bigger than the liver.
That's gargantuous, man.
That's a problem.
My gosh.
His skin is notable for pale, and there is no petechiae or ecchymosis present. We do a few labs here. We get the following back. Hemoglobin of 8.5, platelets of 95,000. We do a peripheral blood smear, and we note teardrop-shaped red blood cells. We do a JAK mutation this time initially, which is positive. And we also now have we follow up with a bone marrow biopsy showing fibrosis or dry tap.
Yeah. So this is a nice one. It kind of sets us up because this is a tough one to diagnose. So primary myelofibrosis is definitely what this patient has going on. So out of all of these, when a patient comes in, like polycythemia vera is a differential, essential thrombocythemia is a differential, those are more likely to cause things like thrombosis. And then for essential thrombocythemia, it's more likely to cause things like bleeding. Right, but they both can cause thrombosis or they both can cause incidents of bleeding. It's just the essential thrombocythemia is more likely to cause bleeding.
Now we had the polycythemia vera, 98% for a JAK2 mutation.
Yep.
ET for 50%, and this one was positive. So what would this one be?
Same thing. It's about the same 50%? Incidence of essential thrombocythemia.
Okay.
Yeah.
All right.
And so for this one, when you think about this patient here, which is kind of like interesting, the biggest issue with primary myelofibrosis is splenomegaly. So they all can cause splenomegaly. So you know how they all can cause thrombosis? And then technically all of them can cause bleeding, but the most likely one is essential thrombocythemia. All of them can cause splenomegaly, but the most likely and severe case is primary myelofibrosis.
Man, that spleen's huge.
Yeah, exactly. So that's the biggest thing. So the way you want to think about it is the most likely one to cause thrombosis, it's all but polycythemia vera. Most likely one to cause bleeding, all but essential thrombocythemia. The most likely one to cause splenomegaly and severe You can do all, but primary myelofibrosis. So that's how you kind of differentiate
breakdown.
them a little bit. And so when I see a spleen that's like about the size of this patient's like leg, you know, in their abdomen, that's like super concerning.
How about the teardrop-shaped red blood cells?
That's another one. So they have anemia, and then they probably triggered them to, they got anemia. Let's get a CBC. We did a CBC, and then we're going to do a blood smear. And when you see teardrop-shaped red blood cells, that tells me that there was so much fibrosis of the bone marrow that as it tried to squeeze some of the red blood cells out of the bone marrow into the capillaries, it made them deformed, and it causes that classic teardrop-shaped. So that's almost always pathognomonic. You know, aquagenic pruritus is pathognomonic for polycythemia vera.
Right.
Teardrop-shaped red blood cells is almost pathognomonic to a degree for primary myelofibrosis.
Now, is this similar like the others where there was a primary and a secondary?
Yeah, that's a really good question. So primary, when you think about this one, I'm definitely concerned when I have splenomegaly. I got anemia, which is the most common cell line to be affected, and I got the teardrop-shaped red blood cells. I got the JAK2 mutation. This is a perfect setup.
Yeah.
The question that you ask is, how do I know if it's primary? So it's due that they all can have a JAK2 mutation. They all could have a CALR. They all could have an MPL. So this is the tough thing. Primary myelofibrosis is it's just that disease that generates that process. You get bone marrow fibrosis directly.
Okay.
If a patient has nonstop cell turnover, like nonstop, so where they're starting off and they're making tons of red blood cells or tons of platelets, such as in polycythemia vera or central thrombocythemia, that constant over 10 years it's about is what they say. Over 10 years of that constant proliferation, they go into a spent or burnout phase, where now they just don't have the capacity of those stem cells to make any more red cells, white cells, or platelets. Instead, it starts triggering fibrosis. So you have to then challenge yourself and say, did the patient have polycythemia vera or essential thrombocythemia in their history, in the past? And then it kept going, and then they converted into secondary myelofibrosis. That's a hard differential. It's a hard diagnosis to make, especially if you don't have the history from prior.
Sure.
In primary myelofibrosis, you don't have any of that stuff. It's just right away the myeloid stem cell is driving the megakaryocytes, driving fibrosis immediately. That's a tough diagnosis to make. You'd have to know if they had PV or ET prior to that.
I was going to say you need to have their history.
Yeah, so that's kind of the challenging thing, but I would say that's the biggest thing is knowing a detailed history prior to their diagnosis of myelofibrosis, knowing if they had polycythemia vera or essential thrombocythemia, because those can certainly turn into secondary myelofibrosis.
Let's say regardless of primary versus secondary, would the treatment be any different?
No, not really. It'd be pretty much the same at this point. So once you have myelofibrosis, the biggest concern here is that you do run the risk of thrombosis. But again, if we talked about it before, thrombosis highest with polycythemia vera, bleeding highest with essential thrombocythemia, and then splenomegaly is the biggest concern. And that's usually where the patients get a lot of problems. But I'd say the biggest thing is you could consider low-dose aspirin, but I wouldn't say it's going to be as high need for this patient. I don't really see any concerning features for them that can suggest thrombosis. What I am concerned about is the splenomegaly. So
yeah, I would be too.
Yeah. So what happens here is hydroxyurea could be considered, but it's really only considered when the cell counts are like super high. And so I don't see high cell counts here. Their hemoglobin and hematocrit isn't really high. We do it for cytoreduction because your goal is to reduce the formation of red cells, white cells, and platelets, and then therefore you'll reduce that risk of thrombosis. I don't really see that. What I do see is a problem with their spleen. And so here's what's really interesting. When you think about this, you have a patient who has this primary problem where you're taking a stem cell and you're converting it into a megakaryocyte. That megakaryocyte's releasing cytokines. It's telling fibroblasts to lay down fibrous tissue, and that's causing the fibrosis of the bone marrow. And that's what's dropping the red cells. And then also when your bone marrow fails, guess who starts to become to compensate? Spleen. So spleen compensates, undergoes extramedullary hematopoiesis to make more red cells, more white cells, more platelets to compensate for your bone marrow failing. And that's why it gets bigger. So if I shut down the pathway where the myeloid stem cell is kind of going to make those fibroblasts activated, I may be able to prevent that downward stream where I prevent fibrosis of the bone marrow, and then I prevent the spleen from having to undergo excess extramedullary hematopoiesis and prevent that spleen from getting any bigger. So the true best treatment for these patients, I'd say first line you should consider is going to be ruxolitinib. If they have severe splenomegaly and anemia, I would just go straight to ruxolitinib. You could consider hydroxyurea because you still would inhibit that pathway, but ruxolitinib is going to be more superior in this scenario.
Anything else?
You could. It's tough. These patients don't have a good prognosis. I'd say out of all of them, they have the worst.
Okay.
And so the chances of them surviving is low. So you'd have to find a really, really, really good patient who's young and has good fitness, or they're able to potentially live a decent life and they're healthy enough to do well with it. You could do a bone marrow transplant. It's really the only thing that can cure this disease because they're going to get worse. Ruxolitinib is the best medical management, but the best curative therapy is an allogenic stem cell transplant, but it's tough to get that for these patients because they don't usually have good prognoses and they're usually old. So these are usually diseases of old people.
Okay.
You don't really see these in younger individuals. It's usually in older individuals. So it's tough to get that one. So if you can find a patient who's younger, they have good medical fitness, you could do it, but it's hard to do that.
Would they ever need a splenectomy?
So yeah, they could get splenectomies. I'd say that we don't do it all the time just because of the risk. But yeah, if you think about it, if the problem that's arising here is that the spleen is constantly trying to compensate and create more red cells and white cells and platelets, you could remove it. The only thing is that other organs would probably start to take over, such as the liver. So the liver is another site where our actual body can try to compensate and make more red cells, more white cells, and more platelets, so they could get worsening hepatomegaly. So I'd say oftentimes we stick to ruxolitinib. Splenectomy can be considered, I guess, in super, super refractory cases.
Gotcha. Okay. Well, then that was all my questions I had, and that wraps up our case series
All right.
on
MPNs, yeah.
MPN's done.
Yeah, this was a good one, and I hope that you guys liked this podcast as well. I know it was a lot of different types of disorders, and I know it was one of these kinds of lectures where the chances of you seeing one of these in your career, you may only get 1, 2 if you're lucky, but at least it's one of those that can help you to become a complete physician, a complete PA, a complete nurse, and really help you to become a good practitioner and to think about these things clinically. Again, remember, these are things that you have to have a high degree of suspicion of, but I think after this podcast that you'll have a good idea of being able to at least think about these and which things really cue my eyes to go towards these. And again, being able to come up with a nice systematic approach of how to differentiate one from the other. And so I really hope that you guys like this podcast and enjoyed it, and love you, thank you. And as always, till next time.